Hi, I'm Dr. Pam.
And I'm Nurse Rena. So, last time, we keep talking about menopause.
Yes.
You were going to, discuss more about perimenopause.
Right.
Yes.
But before we talk about that, I thought you could bring up that
my
you had
issues
another.
right now.
No, not. We could bring that up too. But that you had another patient come in.
Yes.
And
she was young. She was in her 40s, and she says, "Is this a sign of perimenopause or menopause?" She doesn't know the difference still.
Right.
She has anger. She said she gets this anger, and it's like this. And it just wants to come out and kind of like explode.
Yeah, which is
definitely. Wow, that so is.
Yeah. Yes. So probably by her age, she's perimenopause because by definition that means you get to have some of the fun symptoms of menopause, and you still get the periods. It's really fun time. And sometimes
I think she's 48.
Yeah, and sometimes, and the average age of menopause is 51 to 52. And by definition, like we talked about before, the classic definition is 1 year of no cycles. Well, during that time, those women are menopausal. They just don't know it for sure yet because they're not sure if they're going to get a cycle or not. So perimenopause by her age, probably perimenopausal. Okay. There's premature menopause that I wanted to mention before too. And by definition, that's anyone who has menopause before age 40.
Wow.
And that does happen sometimes.
That's a bummer.
And those women actually have high risks not to be on hormones. So because they have a higher rate for heart disease, cognitive or brain function, and bone loss, osteoporosis. Wow. But anyways, so she's probably perimenopause, and that is about 10 years before we stop having periods. We still have we're still making hormones, but they're kind of all over the place, right? And this is a time when some women will skip periods. Some women will have really nasty, closer, heavy nightmare periods, like hemorrhaging periods. So the bleeders, who that's part of perimenopause too. And what's happening is you're still making a lining. The ovaries are still making estrogen. It just kind of goes like this. And then about a week or so before the cycle is when a lot of the women will have the rage or the flashes and the night sweats. And then they kind of get okay at the beginning when they start to make a little estrogen again. And so during that week or two before, that's usually in the perimenopause when most women will have symptoms. And then women won't always ovulate. It's like the ovaries are aging and they're like, this month, not gonna release an egg. And then what happens is the estrogen still builds the lining up, but then without ovulation, you're not making progesterone, because women don't realize this, but when we pop that egg out, the place that's left is called the corpus luteal cyst, and it makes the progesterone. So if you don't ovulate, you don't make that. And then if you get pregnant, that supports the pregnancy. If you don't, what it does is it stabilizes the lining of the uterus, and then it makes you shed all the menstrual blood at the same time. Well, if that is either not present and you don't ovulate, women will often skip, but they're still getting thicker and thicker lining. And then when they finally do have a cycle, it can be really ugly, right? Lots of bleeding. I
never knew that.
And other women, because they're not ovulating, will just like bleed endlessly, like 3 weeks, and then they'll have a week where they don't. And sometimes they'll just have the huge, heavy periods, and those can be bad. And women, one time I had a patient who was using a towel during her cycles. So my advice to everyone out there who needs a towel during your cycle, go to your gynecologist right away, because she ended up needing a blood transfusion in the emergency room. That's how I got her as a patient.
Wow.
So anyway, people, the menstrual blood luckily doesn't have as many red blood cells, because if it did, women would die all the time, right? We lose so much blood. It's mostly fluid. And so, but over time, women can get down so low that they'll show up and they'll have, a hemoglobin of normally it should be 13, and a healthy person 12 or 13, and it'll be down to 8, and that's a big deal. And so you sometimes, if they're symptomatic, you end up having to transfuse and all that. But so perimenopausal women, sometimes they bleed too heavily, too long. Sometimes they skip periods. And then the classic thing is they can have the hot flashes, the night sweats, the moodiness, the aches, the fatigue, and the moodiness, I think, is extra wicked when you're that time. And then it's a little better when you're finally just shut down, not making anything. And the treatments are different, because if I were to give a woman in her 40s, like that patient, if I were to give her menopausal doses, like we talked about last time, the patches, the gels, the pills, those low doses, she would not usually feel better. And in fact, I found a lot of times they would feel worse. So you have to give them higher doses usually. So especially in a bleeder, unless they're a smoker and unless they get migraines with pills and things like that, you treat them with a very low dose oral contraceptive or birth control type pill. So there's one that's 10 milligrams of estrogen. There's one that's 20. I used to like to use the 10 milligrams. It's nice and low. And then that progesterone and that dose of estrogen is enough to make them feel great, and it really works well, actually. And it can also regulate their cycles. Now, if I have someone who said, I can't stand birth control pills, or I get migraines, or I have a history of clots, or they're smokers, I can give them just progesterone. You can use the Depo-Provera shots that you get one every 3 months. You get a big amount, and then it slowly comes down over 3 months. But that one, with long-term use, decreases bone density. So I usually don't use that one, but it does work. And the other favorite one I use is norethindrone acetate, which is a progesterone. Agestin is the brand name. That you can use. It comes in a 5 milligram tablet. And if I have them do 10 milligrams a day, that can really regulate the cycles. And it can also help with some of the symptoms. Sometimes I can get away with using 5 milligrams a day. And sometimes with women, if they go, really, I do great, but that week before my period, I just feel hot, I feel ragey, whatever. Sometimes you can get away with using a estrogen patch that week. Sometimes, but I always wonder, it could be placebo effect. I'm not sure, but if it helps, who cares, right? That's my rule. Because in placebo, I think we should do a whole show on placebo, because it's so cool and fascinating. But in menopausal studies, always the women on placebo, which is a nothing pill or a nothing patch, whatever you're testing, you give half the group the actual hormone or medication, the other half gets the fake one, and you'll get usually at least 40% improvement in the placebo group, and with hot flashes and night sweats. So it's hard to beat placebo. So a lot of the over-the-counter things that are out there, I really think, are probably mostly placebo effect. But if it makes you feel better and it's not bad for you, I'm okay with that. But 40% placebo benefit. So with a lot of the treatments that we're going to talk today, because we're going to talk about the non-hormonal treatments. Because last time we did hormones. And the only thing, last time I didn't mention, there is a drug that is a combination of, and this is for menopausal that I didn't talk about last time. It has estrogen in it. But instead of having a progesterone to protect the uterus, it has another type of medication called a SERM, or selective estrogen receptor modulator. And what that means is that particular SERM, when women take it, in some parts of the body, it acts like estrogen. And it does the exact same thing. Like, helps hot flashes, helps bone density. It's used a lot for osteoporosis, those types of medications. But some of them protect the uterus from thickening. And that's why we give progesterone treatment during whenever we use estrogen in a woman who has a uterus. Well, in this case, if you had someone who says, for whatever reason, I just don't like progesterone, I can't handle progesterone, and it may be more neutral to breast cancer, but when they did the drug, I thought, oh, that's great, because if you're using one of those, SERMs have been shown to block estrogen stimulation in the breast, so therefore used to treat breast cancer. Tamoxifen is a SERM, a selective estrogen receptor modulator.
Wow.
So the benefit, I thought, when it came out, I was like, oh my gosh, you could use it in breast cancer patients. But of course, they don't want the liability. So they said, oh, we didn't study it. We don't recommend it. But I did have one breast cancer patient who we thought we'd go on and treat her hot flashes, because it seems to be neutral you can say at least it's probably neutral for breast cancer. Because remember last time, the one time we talked about the risks, one of the big risk factors for taking hormones is breast cancer increased risk. It's there. It's not a huge risk, but it's definitely there.
Wasn't that with the certain receptors you said?
Yeah.
Okay.
So if you have progesterone, right, if you have hormone receptor positive breast cancer. So but remember the women in the hysterectomy study who did not take the progesterone and just took the estrogen had less breast cancer than placebo.
Right.
See, so then you feel like, well, if you're not taking the progesterone, so that drug, the brand name is Duav, and then I had to write down the generic because it's bazodoxifene. And then it's put in there with conjugated estrogen. So I forgot to mention that last time, but that's an option for women to use as well. And then, blood clot risk is still there with that one. You don't get away from that. And then, but that was my last bit on that. And I wanted to now switch to the non-hormonal treatments, because, we get those questions a lot.
Yes.
And first I'm going to talk about the prescription treatments that we have for women. So if I have someone who doesn't want to do hormones, or they really shouldn't do hormones because they've had blood clots to the legs or the lungs, they've had breast cancer and things like that, or they, most women, I think, in the low dose don't get migraines like they do with pills. So you never know with that one, but that's a possibility. They want non-hormonal. One of the most studied prescription drugs has been the antidepressants. The first one they studied was Effexor, or venlafaxine. And venlafaxine did show that, and they used it a lot in breast cancer patients, because, those patients have to go off their hormones right away, that they definitely do help with hot flashes and night sweats and things like that. And
I wonder why.
It somehow affects that heat regulation center in your brain.
Wow.
Yeah, I know. It's kind of interesting. And then some of the other medication or antidepressants, the SSRIs, which is the selective serotonin reuptake inhibitors, that's like Prozac, Zoloft, Paxil, and things like that. They've been studied and do have some benefit. In fact, paroxetine, Paxil, I always say the brand name. Paroxetine lowered their dose and used it to treat hot flashes and got it approved as a treatment for hot flashes. So, and what was good about it is, those can have side effects. Like they can have a little bit of weight gain, and then the decreased sex drive is a big issue with them.
Yes.
So when you lower the dose down, if you could get some hot flash benefit without the side effects.
Right.
So that can be used. And then the other one that's helpful is the Celexa, is another one that's been studied that's helpful. Some of the other SSRIs they say aren't as good. So those would be the top ones to be used, would be the Paxil or the Celexa. Okay. But if a woman takes tamoxifen, she shouldn't really be on those, because they can decrease the efficacy. And tamoxifen is used to prevent breast cancer recurrence in breast cancer patients. So, so that's the downside. If Effexor or venlafaxine probably has the smallest effect on that, but You have to be careful in those patients on tamoxifen. So those are the biggies. And then gabapentin. Gabapentin is a prescription drug that's mostly used for nerve pain, but sometimes people even use it for sleep because it has a sedation side effect. And that one can really help hot flashes, but a lot of women don't like it because it makes them feel tired, and they're already feeling kind of tired, right? And when you start it, you could start it 100 milligrams at night, and then, you know, I usually will work up to 300 milligrams at night. And then in the studies, a lot of them, they used 300 milligrams 3 times a day, or a total of 900 milligrams a day. You have to work your way up into that because it can make you really tired. So that one I have used, but you have to be careful with it because of the you know, making women feel a little bit tired.
So on that note, if you're taking that low dose antidepressants, I think you have to be careful too with getting off of it and things like that. And same with that GABA, right? You can't just like get up to
smart, Rena. Yes,
you
have to wean off of those babies, especially. That's the one thing yes, for all of them, you have to wean off slowly, especially with the venlafaxine or the Effexor. And that one you have to start low too, because that one has more of a nausea side effect. And so you really have to start at half dose, which is 37.5 milligrams, and then work your way up to 75. And then if you're going off of it, you go to 37.5, and then you know, I tell patients just to keep it with them, skip it when they take it in the morning. I usually recommend morning dose. And then if they start to feel kind of weird, like the symptoms of withdrawal can be different for everyone, when they feel just something that's off, I have them take it, and then eventually they'll go, I haven't taken it and I didn't have it. But you have to, that's so important. You're so right. You have to wean off of it. Now, if you just did it for a few days and you couldn't stand it, you don't need to wean off of it because you haven't been on it long enough.
Right.
Clonidine is a blood pressure medicine, and the one that's used most often to try to prevent hot flashes in women is a patch form. But it does make patients sometimes feel dizzy and tired. In fact, I had a patient come in on it, not for hot flashes, but for blood pressure. And she was going, I can't take it anymore. She was so tired, and it has a sedating effect on her for sure. And it made her feel dizzy. So that one I don't use as much, and it can give dry mouth too. And then there's another medication, oxybutynin, which originally we used mostly for overactive bladder, you know, frequency of urination and things like that. But that can have some help with hot flashes, and the only downside, it causes some dry mouth and some issues, a little bit of dizziness. You don't want to use it in really old women, which you wouldn't for hot flashes anyways. And then there's a new one out, and it's non-hormonal, but it is specific for hot flashes because there are neurokinin receptors in the neurokinin 3 receptors in the temperature setting part of our brain, and that, you know, can trigger the hot flashes. So these drugs are specific for those neurokinins, and it's to help with the hot flashes. And that one's out, and it's called fezolinetant.
Is that the one that's doing commercials?
Oh, probably, because
there's a brand. I should have written it down.
I bet it is. It's newly approved. Yes.
It said specific for hot
Yes,
flashes.
non-hormonal. It's just been approved, and it's just now, you know, going to be talked about. And I was wondering if they were going to come out with commercials. Anyways, they did the study. They did 30 milligrams a day or 45 milligrams a day, and then they did placebo. And after 12 weeks, they found that in the placebo group, 45% of women had less hot flashes. In the 30 milligram group, it was 59%. And in the 45 milligram group, which is what they recommend, it was 64%. Because, you know, it's hard to beat placebo.
I know. So, sorry, say that.
Okay.
The 64% got improvement.
Right. On the 45 milligram dose of the fezolinetant.
Okay.
And 59% on the 30 milligram, 45% placebo. So it did beat placebo, which doesn't always happen. So that one, and then the biggest side effect from that one was headache. And then, so everything's and it's new, so we don't know long term, of course, right? But so that's a new one that's out there now that I haven't really used too much. And then we already talked about using the progesterone. So then there's a whole another category of non-hormonal treatments, and it's things like black cohosh or remifemin, which we talked about last time. And the funny thing with that one is in some placebo trials, right, where they give you black cohosh or placebo, and then they ask women how they feel. In some of those double-blinded randomized trials, it helped, and in some of those trials, it didn't help compared to placebo. But it's a pretty harmless herb, right? So I have patients who will take it sometimes and feel like it helps.
I've heard it too.
So black cohosh, and then there's a multitude of products out there that have combinations of things like ginseng, ginkgo biloba, dong quai, the Chinese herbal type of remedies, which honestly, no one's really studied those properly, right? Because there's no money in it. And so they're not going to be able to do a double-blinded randomized trial on those things. And so it's hard to get information. Now, when they've looked at some of the studies done, a lot of them don't beat placebo, right? But then who's doing the study too, right? Do we trust the person because they want you to buy their drug? I'm not sure, but I think American Botanical Society is it could be a good resource to look some of those things up. But there's other physicians out there, gynecologists. There's one, I forget her name, who really likes to use like specific ginsengs and ginkgo biloba combinations and things like that. But she also, if someone comes to her with menopause, she puts them all on like a keto diet type, low carb, low sugar, and then she has them do yoga and meditation, which helps a lot with stress. And so I think those things alone would make a lot of women feel really good. That's why I think it's smart. If you have menopause and you're feeling horrible and you're really not excited about a prescription or buying a bunch of supplements. Oh, I know the one I wanted to mention though really quickly is ashwagandha. Ashwagandha has a lot of benefits, and I think that one I do recommend. I take it. Not consistently.
Don't people use it? I gotta bring this
because it can make you feel calmer. A lot of people take it for calmness.
Yeah, for calmness.
And it has other benefits as well. And so that one, I've had some patients feel like that one helped, and I think that one, again, it's not harmful. It has a lot of other benefits. So ashwagandha can be. There's another, one rhodiola that also can help with calming, and that one some women say helps with menopause. But anyways, what I was getting back to is if you're really not feeling good and you're entering this phase of life, like I mentioned before, you have to start with, how's my diet? Am I eating a bunch of crappy crap? Because we tend to eat more crap when we're feeling bad, when we're not sleeping.
Sure.
You can't.
And we want that sugar for
that
the energy.
Sugar, sugar is the worst, right? Yeah. Because our risk for diabetes goes up when we hit menopause, and then we're,
Why does the risk go up?
Because when you hit menopause, you lose the estrogen, which actually helps keep the fat more distributed, like, in women traditionally in the hips. You lose that estrogen. And then women tend to, put more weight on in the mid-abdomen because the cortisol, the stress hormone, naturally goes up when you hit menopause. And that raises sugars. And then we get
Then that's huge.
And then some women put weight on when they hit menopause, right? Because they're losing muscle.
Everybody says they do.
They're losing muscle. They're Sometimes,
wow.
you just need to eat less and less as you get older. And women often don't because they don't think of that. And they can eat the same thing and slowly put weight on.
Well,
And
that's
so,
also contributing, which we will do another podcast about exercise.
Yes. Yes.
That's where the resistance training.
Right.
Yes.
Yeah. Yeah, that's a big deal. So I do think that the first thing we all need to do when we're entering this time of life is to clean up our lifestyle. And look at healthy diets like the Mediterranean diet or the paleo diet or the
whichever one feels good, because I'm one of those that I've tried the paleo myself. Yeah. I feel terrible.
I love it. I feel fantastic.
So, everybody, and a lot of people. So, pick one that's healthy, but you feel good.
That's healthy, but it can't be full of processed foods. And honestly, most of us don't need snacks like crackers and chips and things. And so we have to clean that up, and then you have to move your butt, which, again, maybe next time, right? We'll talk about that. Because I think we need to talk about exercise for women. Perimenopausal, menopausal.
With that, yes. Because the importance of muscle
getting
mass.
the muscle, keeping it up.
Not only with aging, but now we're, including that menopause. And I did not know about the insulin and wow.
Yeah, so
more reason to exercise.
Oh yeah. Oh yeah. And then because we're aging, we're more at risk for high blood pressure and things like that too. And then, isometric exercises, they say, really help high blood pressure. Right? Like a wall squat or a plank. Anyways, but we'll do that next time. But yeah, so diet is super important. Moving your bottom is super important. And then I love meditation. I want to do a whole podcast on that because that has
show the studies.
There's so many studies. It's the coolest topic. Mm-hmm. And I do think it helps. I really do. It helps boost our immune system. It lowers your cortisol, which, you go up when you hit this time of life. And it has so many health benefits. So it is the time when we could start that practice.
I think it'd be fun to talk about because meditation to me, I think still has that negative, where, they're saying even if you are dancing, that can be a type of meditation.
Yes, it's whatever.
Gardening.
Shut your brain off from going.
Correct.
Right? And so, there's lots of forms of it. Mm-hmm. And I used to think it was stupid. Right? And so, and then I read all the medical studies on it. So we'll talk about that too, because I do think this is non-hormonal treatment, the main one that we should all do. Right? And then if you still are really suffering and your quality of life is just shot, you can start, by the time most women, I mentioned this last time, by the time most women come to see me, they've tried everything. They've tried all these non-hormonals. And they're really suffering. So those women can benefit from hormones. And, hormones did get a bad rap. There are some benefits, for sure, like we talked about last time. We just have to be careful how we use them and things like that. But,
So you're still talking peri, are you?
Oh, well, yeah, for both peri and, no, I was mainly, when I was talking about all those things, either. Wherever you're starting to feel bad, which could be perimenopause, hot flashes tonight, so it's moodiness, the rage, like that one gal, and then menopause for sure as well. Both. Non-hormonal treatment.
Gotcha.
Lifestyle, you can't go wrong. You really have to, we all need to really focus on that first. Mm-hmm. And it's hard because you don't feel good. So it is really hard.
It is really hard. It is.
Yeah.
And what's Rena suffering through right now?
Oh, yeah. And you're a dizzy blonde today.
Yes, I decided to go off my patches to see how I would feel. I'm 60.
Your estrogen patches.
My estrogen patch. Just pretty kind of curious.
Yeah, which is
because I've been doing it since
it's what I recommend. You go off and you see how you feel.
And I feel different. I can't explain it. And now I'm getting dizzy.
So I wasn't
3 weeks.
Right, and I think if you think it's that, it's possible.
Oh, my heart is starting.
Oh, and the heart palpitations, because we did mention that before, but symptoms of menopause for sure, so I wasn't sure about the dizziness, so I looked into it, and there was a Japanese study that showed 30% of women who were coming into the menopausal clinic for help reported episodes of dizziness. And, it can be related to dehydration, to sleep deprivation, and things like that. But there probably is a hormonal connection, you would think,
well,
right?
I think when you don't have, nothing's changed, but yet one thing,
right?
Let's say for me right now, the patches.
Yeah.
I'm like, wow.
Yeah. So what'll be fun is when you restart them, because you told me you were going to.
Absolutely.
When you restart them, it'll be fun to see if it improves. That's how I learned about arthritis. Yeah, because I think that's important. Arthritis, they had taught us nothing about arthritis, but I had the patient who was dramatically, when she went off her hormones, because I said she'd been on them a while, and I said, why don't you go off? And she called me, and she goes, I feel like my joints are in so much pain. I can't stand it. I can't live this way. And I said, well, go try them. Let's see if it's related. Go right back on them. Boom, gone.
I know.
And just like Mom for anxiety, when she had that horrible anxiety, as soon as she did the hormones, it disappeared. Yeah. So it'll be fun to see, because then
anxiety too for me, maybe.
Yeah, that's true, and that can contribute to the dizziness, right? It's.
So one of the things you mentioned was lasers.
Oh,
I wanted you to mention that
because
again.
I think it was, I don't know which one podcast, but we talked about vaginal estrogen, because it has lower risk factors than if you take a patch or
and also that you still can take other estrogen, because that's a myth still.
If you're on something systemic and you're still dry and have painful intercourse, absolutely, some women will need both.
Yep.
Vaginal product and that. We talked about there's a ring, there's the cream.
I just think
there's the newer
I have
ones.
to say, because that's one thing I kept hearing from patients, was doctors saying, because you get the vaginal estrogen, you cannot.
Oh, you mean the systemic?
No, when they were just doing for dryness.
Oh no, that they couldn't do systemic. No,
yep.
That's silly.
Oh, sorry.
But you wouldn't do. I could, like, if you came and said, "Oh my God, I have hot flashes, night sweats, I have rage, I'm crying all the time, whatever," I would never give vaginal estrogen. It wouldn't help, right? Because it's safe. That's why it's cool for women who have breast cancer, like we talked about. But you're right. We didn't mention the laser treatments. The most common one that's used that has been FDA approved is called the Mona Lisa. And it is FDA approved for vaginal atrophy. And what that means is, as we age and we stop making estrogen,
which helps.
Yes,
the tissue.
The thickness of the vaginal tissue that is beautiful, thick with folds like this, turns into this flat paper-like appearance, and it doesn't work well. It doesn't have pliability, so pain with intercourse, feels dry, feels itchy, feels terrible.
Bladder.
Right, and it affects the bladder because, like we mentioned before, estrogen keeps the bladder tissue lush and plush and makes it less likely to get a bladder infection, which is why one of the main treatments for women who are, especially, like, they did a big study, women in their 80s getting frequent bladder infections, they gave them a little vaginal estrogen. It was like 86% of them quit having them. It's a big deal.
It is.
So anyways, the FDA-approved Mona Lisa, it's a laser treatment you get, and it's supposed to stimulate, collagen and make the vaginal tissue healthier like it used to be. The recommendation is 3 treatments, 6 weeks apart, and then like a yearly maintenance type thing. It's not cheap. I think the prices have gone down, but
have they? Because
that's what I
think they were around 1,000 per treatment.
Right.
Yes.
I heard they're down a little bit.
Oh.
Yeah. So I need to look into that. I should know that, actually. But anyways, I've had several patients do it and feel like it helped. I think that it depends on the person. One thing that they found when they started to do these, because a friend of mine does them, is they found that women would say, "Wow, my leaking of urine is gone." Now, it won't work for really heavy duty leaking, but for mild incontinence that a lot of women have after they have a baby, especially, they'll notice that, and they really, of course, that's a huge thing. So they love that. So there are women who really like it. You did it. You said you didn't mind talking about it.
Yeah, I mean, I don't know. Again, big difference? No, but then I only did 2. I should have done it another time, but maybe.
What made you not do the third one?
I think it was because I'm lazy and.
Yeah, like all of us. Because I'm a bad
do it.
Okay.
Yeah.
Yeah. So,
and it may. I guess they take.
But
pictures.
You weren't blown away by it.
Right. But then you do hear
Mm-hmm.
some that are.
Yeah, and then I've had some who said they didn't get a benefit.
Yeah.
So I think it just depends on the women
right. Try sometimes.
Yeah. And I've had women, especially if I have a breast cancer patient, of course, it's great, right? Hey, why don't try, see what you get from it first. Now, a lot of women will still need estrogen, and they'll do the laser, it'll feel better, but they will still use estrogen. Right. I think on occasion someone won't, but I think most of the time it doesn't eliminate your need for the prescription, which would be cool.
Another thing, a topic we haven't discussed was sex. I think that would be another podcast. Is the laser supposedly, because it rejuvenates, makes it a little more pleasurable.
Yeah, and that, no one studied that really, but that's...
Do the creams, though, I think when it helps women.
Oh, yeah, well, let's face it, one of the biggest libido crushers or sex drive crushers is pain.
Right.
It's already hard enough for some women because we'll do a whole podcast on that libido, but women are more sensitive to stressors of any kind, and then we lose our sex drive. But you can imagine if you're like this.
Yeah, so I think the creams helps that. I do.
Yeah,
and
that's
then,
for
and
sure.
then I did hear that the laser did do that for some women. So, but again, another topic.
But it's important, and then I think that hormones. I have had women say it helped them feel a little better about their sex drive.
Yeah.
I think because we sleep better. If you're having
you're exercising. You're so true.
You're just feeling better.
Could be part of that.
So I think it's part of that as well. But
true.
Just like the weight gain, when you don't gain weight with hormones, and people will say, "Oh yeah, you can lose weight," but I think if you do, it's from all the good things you do because you feel better.
Okay, so we are running out of time. We're getting the nod from our sister over there.
Yep.
I think, next time I'm going to talk about the exercise aspect.
Super important.
Okay.
Excellent. Yeah. And then I can ask the question.
Yes. Okay.
Okay.
Thanks, everybody.
Thanks.